Greetings, everyone. My name is Chad, and this is my presentation on dilated cardiomyopathy. The hallmark of dilated cardiomyopathy is ventricular chamber enlargement with impaired systolic contractile function. So if you notice the picture on the right here, that large ballooned out ventricle, and that's going to give a weak contraction. And that's what we look for in dilated cardiomyopathy. And we can see this in one chamber, as shown here, or frequently we see all four chambers enlarged as well. The prognosis with this disease tends to be related to the severity of the disease at the initial diagnosis. And one of the things we consider is the 5-year mortality rate. The 5-year mortality rate for DCM is estimated to be between 40 and 80%. 1/3 of patients will experience spontaneous improvement of heart function after diagnosis is made. However, the prognosis for patients with persistent DCM who do not undergo cardiac transplantation is poor, and the average 5-year survival rate is less than 50%. And there are certain conditions that make this prognosis a little worse, things such as renal failure, ejection fraction of less than 35%. If you notice cardiomegaly or a very large heart on their chest x-ray, if they have low exercise tolerance, or if they continue to have elevated BNP levels despite medical treatment. And we'll discuss some of these things a little bit later. Now let's consider some of the epidemiological factors with dilated cardiomyopathy. We have an incidence of 148 per 100,000, which just means for every 100,000 people you have in a population, 148 of them will receive a new diagnosis of the disease. And with this disease, we also have a prevalence of 920 per 100,000, which simply means if you were to randomly sample 100,000 people in a population at any given time, 920 of them would have that disease. And we notice that dilated cardiomyopathy affects males more than females at a rate of about 3 to 1, and it will also affect blacks more than whites at a rate of about 2.5 to 1. Okay, let's consider some of the causes. This could be idiopathic, which just means we simply don't know what's causing the DCM. There are familial and genetic factors, and as we do more research, we're finding a lot of those idiopathic causes did have genetic factors related to it. There are inflammatory factors, and these can be infectious or non-infectious. Inflammatory factors, a couple examples of infectious factors would be a viral disease or Chagas disease, which is a tropical parasitic disease caused by a protozoan known as Trypanosoma cruzi. Some non-infectious inflammatory factors include some connective tissue diseases, for example, Marfan syndrome, or peripartum, which is around childbirth. And these patients will see heart failure symptoms that begin about 1 month prior to delivery and last up to about 6 months after delivery. We also have cardiac causes or toxic cardiac causes, things such as chronic alcohol ingestion, and this is one of those environmental factors that we can alter. But alcoholic cardiomyopathy does develop in a small number of people who consume alcoholic beverages excessively and chronically. And although the pathophysiology is unknown, ethanol is thought to impair cellular function by inhibiting the mitochondrial oxidative phosphorylation and fatty acid oxidation. And this is an important cause to identify because it is potentially reversible. Another toxic and reversible cause would be cocaine use. And it should be noted that although chronic alcohol intake is associated with an increased risk of heart failure, analysis of the data from a large randomized controlled trial showed that consumption of up to 2 alcoholic drinks per day was not associated with any increase in adverse clinical effect, and in fact may reduce the risk of fatal myocardial infarction in patients with left ventricular systolic dysfunction. Another cause that would be toxic would be something like chemotherapy. There are metabolic causes, for example, hypothyroid, which is another potentially reversible treatment if we can correct that thyroid imbalance, or chronic hypocalcemia or hypophosphatemia. And finally, neuromuscular causes, diseases such as Duchenne muscular dystrophy, or DMD, which has a genetic factor to it as well, and we'll get into that a little bit later. So classic signs and symptoms, what are these patients going to look like? Patients with dilated cardiomyopathies usually present with symptoms and signs of congestive heart failure. The symptoms, the things that the patient are going to complain about, include dyspnea or shortness of breath, orthopnea, so they get short of breath if they lay flat, weakness and fatigue, weight gain in these patients with fluid retention, despite loss of appetite. You'll see abdominal bloating and nausea. Often see pedal edema, or that swelling to the ankles. They may complain of palpitations and syncope. Some signs you'll notice with dilated cardiomyopathy include increased jugular venous pressure, a small or narrowed pulse pressure, pulmonary rales, or what we call crackles, is that fine fluid sound in the lungs, peripheral edema, presence of extra heart sounds, S3 and S4. And you'll often hear regurgitant murmurs, and these have a few cardiovascular effects. For one, the excessive volume and pressure load placed on the atria causes the atria to dilate and can often lead to atrial fibrillation, so you may notice that on the monitor. The decreased forward flow into the systemic circulation decreases cardiac output. And the regurgitant volume returning to the ventricle during diastole causes an ever greater volume load to dilate that left ventricle even further. Another sign you may see is the hepatojugular reflex, and this is an elevation in venous pressure visible in the jugular vein produced by a firm pressure with a flat hand over the liver for 30 to 60 seconds. So as you push on their belly a little bit, you'll see the jugular vein start to distend. These patients will often have a resting tachycardia as they attempt to compensate for that drop in cardiac output. They may have pale or cyanotic or blue appearing extremities, and cardiomegaly, a large heart, typically with an increase in left ventricular mass without an increase in left ventricular wall thickness. Some non-classic symptoms that they may present with are some abnormal EKG findings, both atrial and ventricular arrhythmias, and systemic embolic events, which is often related to the atrial fibrillation. Okay, let's consider some assessments and diagnostic tools. We'll start with the ECG, or the 12 lead. Some things you'll notice: the ECG will usually demonstrate atrial and ventricular enlargement. Patchy fibrosis can result in a wide array of arrhythmias, most importantly atrial fibrillation and ventricular tachycardia. and that's because the AFib can lead to the clot formation, and VTAC can turn to a lethal arrhythmia. You'll often see conduction defects such as a left bundle branch block or right bundle branch block. You may see diffuse repolarization abnormalities, so ST segment and T wave abnormalities. And regions of dense myocardial fibrosis may produce a localized Q wave resembling pattern of previous MI. So we'll start with this one. This is right atrial enlargement. And if you take a look at leads 2, 3, and AVF, those inferior leads, you'll notice those very tall, kind of peaked, wide P waves. And that's what we'll see with right atrial enlargement on the 12 lead. If the right ventricle is dilated or enlarged, it might cause a bit of a right axis deviation, and that's what we're seeing here with the mostly negative S wave in lead 1 and the large R wave, large R wave in V1 and the deep S in lead 1. And again, you see in the inferior leads that tall peaked P wave. LAE, or left atrial enlargement. Here we're looking at mostly leads V1 and lead 1. Often lead 2 will show this as well. But if you see in lead 1, over here, this M-shaped P wave, that's what you'll see with left atrial enlargement. And that bigger hump towards the end of the P wave is the delayed, slow and wide conduction through the left atria there. And this is just what it appears like in V1. You may see left ventricular hypertrophy type changes on the 12 lead as well. And here we're comparing basically the left lateral leads and then the right leads. And you'll see a large depolarization away from the right facing leads, such as V1 right here. And then the leads that look at the left side of the heart, V5 and 6, usually over here, you'll notice these very large R waves. And that large depolarization just means that left side is either dilated or hypertrophied. Another 12 lead finding we'll often see are bundle branch blocks. These are typical as the ventricle stretches out. It pulls the conductive tissue and may destroy that conductive tissue, and you'll see either right or left bundle branch blocks. And so these are the typical findings you'll see in each. With the right bundle branch block, you look at lead V1, and this should be mostly negative. And instead here we see a large R prime wave, making that wave mostly positive. And you match that with the left lateral leads, you'll see this slow and then deep conduction away. That means the right side of the heart is being depolarized late, and it takes longer as the right bundle branch is destroyed. So those are the findings you'll see there. And with the left bundle branch, we see the opposite. We'll see a wide QRS, but in lead V1, the lead that looks at the right side of the heart, we see this wide wave going away from it. And then in the leads that look at the left side, big slow depolarization towards the left side as the conduction in the left ventricle has to proceed by a slower cell-to-cell transmission. So here are repolarization abnormalities. With these, we're looking at ST segment and T waves. And you can see on this 12 lead, it says non-specific abnormalities. But you notice in these leads, it's a little flat, maybe almost even inverted. Here we see T-wave inversion. Looks like some ST depression and T-wave inversion over here, maybe over here. incomplete right bundle branch block we see. If you look at this, this deep and kind of slow S wave here in lead 1, that's what shows the incomplete bundle branch block. Not complete because the QRS segment is still not over 0.12. But we'll see depolarization abnormalities with dilated cardiomyopathy as well. And finally, the Q waves. In some leads, it's normal to have small Q waves, such as here. But when you see Q waves like this deep and often wide, that just means that where that lead is looking, it's first seen almost like looking through a window at the opposite side of the heart, where the tissue directly under that lead is electrically inert. And that can mimic a myocardial infarction. Another thing we look at is echocardiography with these patients, and diagnosis of DCM almost always can be confirmed by a transthoracic echo or TEE. And this will typically demonstrate 4-chamber cardiac enlargement with little hypertrophy and a global reduction in systolic contractile function. Global just means the whole heart is not contracting well. Occasionally we'll see mitral and or tricuspid regurgitation as well, as those walls dilate and they pull that ring apart for the valve. The valves can't close as well and we'll get regurgitation. We can also send these patients to cath lab, and there, if we do hemodynamic studies, these typically show elevated right and left-sided diastolic pressures and diminished cardiac output. And so as those valves get leaky and the ventricle dilates, more volume remains in those ventricles, and that builds up the pressure, and then the muscle can't eject as well because of the systolic dysfunction. And so volume just fills the ventricle and it builds up that pressure. Occasionally at cath lab, a transvenous biopsy will be performed of the right ventricle, and this is in an attempt to identify or clarify the etiology of the cardiomyopathy, looking for sarcoidosis or things like that. MRI may be helpful. This is a non-invasive imaging of the heart and its adjacent structures with the use of strong magnetic fields. And we can do this to check for the appearance and thickness of ventricular myocardium and pericardium. So in this one, you see the thickness may be fairly normal, but this ventricle will be very dilated. We have some labs that can help us in our diagnosis of dilated cardiomyopathy. One important one is BNP, or brain natriuretic peptide. And BNP has a high sensitivity and specificity for heart failure. And what's going to happen is BNP will be released from myocardium of both ventricles, but predominantly from the left ventricle. Abnormal pressure or stretch within the ventricle leads to this release. And as we've seen with DCM, we'll often see both of these. Levels greater than 100 are considered abnormal. Levels between 80 and 100 are borderline, but most patients with heart failure will have a BNP level above 400. So if you see that, that can help in our diagnosis of heart failure related to our dilated cardiomyopathy. Okay, let's consider some genetic factors. Up to 30% of instances of otherwise idiopathic dilated cardiomyopathy do suggest some sort of familial inheritance. And we'll see things such as autosomal dominant, autosomal recessive, X-linked, and mitochondrial patterns of inheritance that have been described in the literature. And these lead to defects in contractile force generation, force transmission, energy production, and myocyte viability. identifiable mutations occur in genes that encode for cardiac cytoskeletal proteins, myofibrillar proteins, and nuclear membrane proteins. So we'll take a look at each of these. First, the cytoskeletal proteins. These are, the cytoskeleton is sometimes called the cellular scaffolding. So the proteins that have been identified with mutations are Desmin, Dystrophin, Myosin-Binding Protein C, the Sarcoglycan complex, and Titin. So this first one is Desmin. This is found encoded on chromosome 2 in the DES or DES gene. 8,363 base pairs. It's got 470 amino acids. And this protein helps form a stable intracytoplasmic filamentous network connecting the myofibrils to each other into the plasma membrane. And so it's what we see here. Here's a protein connecting it to the membrane, another Desmin connecting the myofibrils to the mitochondria and to the nucleus. So it just kind of attaches everything within inside the cell. And some instances of dilated cardiomyopathy are related to mutations in this protein. Another cytoskeletal protein is dystrophin. This is found on chromosome X, the DMD gene. Dystrophin is a large rod-like cytoskeletal protein which is found at the inner surface of muscle fibers. It's part of the dystrophin glycoprotein complex, which bridges the inner cytoskeleton and the extracellular matrix. So it's going to bridge the cytoskeleton in here with everything out here. Another protein that they found mutations is the Myosin-Binding Protein C. This is the MYBPC3 gene found on chromosome 11, right there at that red notch. This protein is found in the cross-bridge bearing zone, or the C region, of A bands in striatum muscle, and the cardiac isoform is expressed exclusively in heart muscle. Regulatory phosphorylation of the cardiac isoform by cyclic AMP-dependent protein kinase, or pKa, upon adrenergic stimulation may be linked with modulation of cardiac contraction. But it's this protein right here that we're talking about. Also, there have been defects in the sarcoglycans, or the sarcoglycan complex, this whole complex right here. The sarcoglycans are a family of transmembrane proteins involved in the protein complex responsible for connecting the muscle fiber cytoskeleton to the extracellular matrix. Remember, we talked about that a couple slides ago with the dystrophin as well. And this helps prevent damage to the muscle fiber sarcolemma through shearing force. So when we see mutations here, or with the dystrophin as well, these tissues can get damaged much more easily through the shear force that they often endure. Another protein found to be mutated in dilated cardiomyopathy is Titin. This protein right here, it's kind of anchoring everything right here in the sarcomere. And Titin contains binding sites for the muscle-associated proteins, and it basically just serves as an adhesion complex to hold everything together there in the sarcomere. So when that is mutated, you can see how we would have damage to the sarcomeres themselves. Next, we'll consider the myofibrillar proteins. These are kind of the work proteins of muscle. This includes the beta-myosin heavy chain, all your troponins, the alpha tropomyosin, the essential myosin light chain, and actin. So we'll begin with the beta-myosin heavy chain. And that's this protein right here. The beta-myosin heavy chain is the MYH7 gene encoded there on chromosome 14. And this is involved in muscle contraction through cyclic interactions with the actin filaments and involved in creating that contractile force. It's regulated by phosphorylation via myosin light chain kinase and by the intracellular calcium concentrations. Next, we have the troponin T, and that's part of that troponin complex there. Troponin T is the TNNT2 gene found here on chromosome 1. The tropomyosin binding subunit of the troponin complex is what we have here with troponin T. It's located on the thin filament of the muscle, the actin filament, and regulates muscle contraction in response to alterations in the calcium ion concentration. The next part of the troponin we have is the troponin I complex, or troponin. It's the inhibitory subunit, so you can remember I for inhibitory. And this will act by blocking the actin-myosin interactions right here with the troponin C complex as well. This is the TNNI3 gene encoded here on chromosome 19, so we'll see mutations here. And that will be related to DCM as well. Finally, with the troponins, we have our troponin C complex. The TNNC1 gene located here on chromosome 3. This protein has 161 amino acids, and the binding of calcium to the troponin C abolishes that inhibitory action of troponin I and will thus allow the interaction of actin with myosin to give us that, that contraction. Next, we'll see mutations in our alpha tropomyosin proteins with dilated cardiomyopathy. This protein is the TPM-1 gene located on chromosome 15. And it is a widely distributed actin binding protein, provides stability to the filaments, also functions in association with the troponin complex to regulate that calcium-dependent actin-myosin cross-bridging during muscle contraction. Next, we have our essential myosin light chain protein. This protein right here. This is, the gene for this protein is found on chromosome 12 here, and it is a linker between head and tail and is the site of regulatory myosin light chain binding. It's involved in muscle contraction through cyclic interactions with actin-rich thin filament. This protein is regulated by phosphorylation via the myosin light chain kinase and by the intracellular calcium concentrations. And finally, we have our actin. This is the main protein of the thin filament of the myofibril. This is the ACTC1 gene located here on chromosome 15. And as you can see, all those myosin binding sites, that's where the myosin heads will actually bind when the tropomyosin complex moves off of those binding sites. And that's where it'll pull the thin filament to give that muscle contraction. But when we have mutations with these proteins, you can imagine we get that weaker or systolic dysfunction seen with dilated cardiomyopathy. And then finally, there's the nuclear membrane proteins. One mutation has been found here, and that is in the Lamin AC protein. Lamin AC is the LMNA gene found encoded here on chromosome 1. And these proteins are thought to be involved in nuclear membrane stability, chromatin structure, and gene expression. And so if we get problems with that, we'll have problems with our dilated cardiomyopathy as well. So what are our treatment options? The main goal of therapy with these patients is to relieve symptoms, prevent complications, and improve our patients' long-term survival. And symptoms associated with dilated cardiomyopathies are usually significantly improved with medications. Clinical trials have confirmed that the risk of death is reduced with the use of ACE inhibitors, angiotensin II receptor agonists, beta blockers, and other drug combinations. So we'll consider some of these pharmacologic therapies. Before we get into the specific drugs, I want to look at this diagram because this will help understand why we give some of the drugs we give. And you see we start at the top with systolic heart failure and what that leads to. The reduced cardiac output will immediately lead to a sympathetic nervous activation. That'll cause vasoconstriction, which will immediately lead to cardiac filling pressures and a worse dilation of the weakened ventricle. The reduced cardiac output also activates our RAS system, or renin-angiotensin-aldosterone system, and we know many of the effects of angiotensin II. It's the potent vasoconstrictor. It also increases sympathetic activity. It increases fluid retention, which will also lead to that increased cardiac filling pressure. And we'll get this vicious cycle of the body trying to compensate for the reduced cardiac output, but those compensatory mechanisms eventually worsen that cardiac output. So here are the drugs we give. One of the most important is the ACE inhibitor, or angiotensin converting enzyme inhibitor. And these are prescribed for all patients with reduced left ventricular ejection fraction. And as we know, we inhibit the conversion of angiotensin 1 to angiotensin 2, and we inhibit all of these other effects that come with angiotensin 2. The increased sympathetic activity, the increased fluid retention, increasing the volume overload to the ventricle, and the vasoconstriction will also increase the return to the heart and then increase the force that the ventricle has to pump against, and we already have that weakened systolic function. Another drug we give is loop diuretics, such as Lasix, which is the furosemide or torsemide. And these act by inhibiting the sodium chloride potassium cotransport system there in the thick ascending loop of Henle. So we know that water follows salt, and so what we do is when we inhibit that system, we keep the salt and thus the water in the limb, and it'll be sent to the collecting duct to be sent and produces urine. So basically we prevent that water from being reabsorbed back into the vasculature. Digoxin is another drug that we can give, and what we are interested in with this drug is the mechanical effect. We can increase cardiac output. Digoxin helps increase the force of contraction by blocking the sodium-potassium ATPase pump, which has an effect on the sodium-calcium exchanger and will basically lead to a increase in the intracellular calcium, which helps with that troponin binding and the stronger muscle contraction. Additionally, we can give beta blockers, and these would be drugs such as metoprolol, carvedilol, and in the heart tissue, we're mainly interested in the beta-1 effect. And so what happens with beta-1 is or when you get that increased sympathetic activity, it'll stimulate the beta-1 adrenergic receptor. And this is a G-coupled protein receptor. The G protein will activate adenylyl cyclase, which will convert the ATP to the cyclic AMP. And the cyclic AMP will convert the inactive protein kinase to active protein kinase. And the active protein kinase will then go work on the L-type calcium channels, these long-acting calcium channels, and also go to the ryanodine receptors in the sarcoplasmic reticulum. And what all this does is increase the calcium levels within the cell, and so you'll get a stronger contraction. They speed up the heart rate and the force of contraction. And normally, as a compensatory mechanism, this is good, but it's going to increase the workload on the heart. And when we already have a weak, dilated ventricle, we want to reduce that workload on the heart. So we can give beta blockers to block those effects. Additionally, we give nitrates to these patients. The reason we give nitrates, and you can see the flow, the mechanism of action here, but we want to vasodilate and decrease that venous return to the heart, because as the heart is dilated and has that weaker contraction, it can't eject that volume that's in the left ventricle. And so as more blood returns to the left ventricle, the pressure just builds up, and it can lead to further heart failure, further strain on that heart. So by vasodilating with the nitrates, we can decrease that venous return to the heart. And that ultimately occurs through the phosphorylation of the myosin light chain in the muscle we talked about earlier, leading to that relaxation. With patients who are experiencing atrial fibrillation, we're also interested in giving warfarin. And this is because as blood kind of stagnates in that fibrillating atria, the atria doesn't eject, it's dilated and it's not really squeezing blood out. So the blood will settle there and it can tend to form clots. And if those clots get knocked loose, that's when we get those systemic embolic events that are at higher risk for stroke, higher risk for myocardial infarction, and depending on which atria, they're found in pulmonary embolism as well. So we'll give warfarin to inhibit the formation of those clots, and you see the mechanism here, mainly by blocking the vitamin K dependent production of vitamin K hydroquinone. We block the activation of clotting factors. It needs the vitamin K dependent carboxylase to activate those clotting factors, and warfarin will block that activation mainly via the vitamin K mechanism there. Another treatment option is the AICD, or implanted cardiac defibrillator. Since these patients are prone to dysrhythmias, potential lethal dysrhythmias, VTAC and VFib, it's a good idea to have a defibrillator implanted, which can deliver a shock immediately if they go into one of these lethal rhythms. And we know that quick defibrillation is one of the best chances these patients have of survival. Also, these patients may require a pacemaker, biventricular pacer. You'll see here the two probes in both of the ventricles. If these patients have severe conduction system abnormalities, heart degree, third degree blocks, or severe bundle branch blocks, things like that, they may need to be paced on a continual basis, and so we can give them these biventricular pacers. Given the ventricular wall stretching, it tends to stretch out that ring, the annular ring for the valves. It's this ring here. And so these patients may require a annuloplasty, or we just go in and fix that annular ring for the valves. And you'll see here the torn leaflet. They'll go in and suture that and then reinforce that annular ring to keep that valve functioning. Occasionally these patients may need just a complete valve replacement if there's other sort of fibrotic damage going on, or if the valve has been damaged so much through the stretch and the wear and tear, they may also need just a valve replacement. And ultimately, we like to give our patients heart transplant if we can. The problem is there's such a shortage, but the heart transplant, or there are some assist devices, LVAD, left ventricular assist devices. These things are our patients' best chance at a prolonged survival. The current 5 to 10 year survival rate after transplantation is 74% at 5 years and 55% at 10 years. So if you remember, less than half of our patients made it to 5 years before the transplant. So despite our medical therapy and surgical repairs, without a transplant or some sort of assist device, many of these patients will succumb to their disease within a matter of a few years. So these were my main resources for this project. I'd like to draw attention to the Weizmann Institute of Science. That's where they have a lot of good information on genes and proteins, and so I encourage you to go look these people up. And I'd like to thank you for watching my presentation, and I look forward to seeing all of yours.